Patricia Benner is a contemporary theorist who has made significant contributions to philosophical nursing thought. Her work provides a rigorous framework to outline the career trajectory of professional nurses and their clinical competency development. Her novice to expert model has inspired considerable research initiatives, practice programs, and healthcare mentorship and preceptorship-based training. To this day, her work continues to be a guiding reference for development and nursing leadership skills acquisition, as well as for the recognition of expert nurses on the basis of clinical experience. Benner's theory is particularly pertinent to the context of a nursing educator, as their mandate involves direct clinical mentorship and educational activities. Keeping this in mind, I'm going to explore and critically analyze the novice to expert model through a fictional lunch exchange between Patricia Benner and myself, a rehabilitation-based clinical nursing educator. In choosing a theorist to have lunch with, I would sit with Patricia Benner specifically to discuss her novice to expert model. So fundamentally, this model proposes that nurses pass through 5 stages of proficiency, from that of the beginner to the expert. As a nurse moves through these levels, they develop a deeper and more intuitive grasp of the nature of their profession. They improve on their ability to link more abstract academic conceptualizations into practical clinical knowledge. This longitudinal trajectory develops on the basis of a nurse's intuition and practical experience rather than on the basis of their academic training. My choice of theorist reflects the direct applicability of Patricia Benner's work to my practice as a rehabilitation nursing educator with less than a year of experience. I would choose my institution's break room for the setting for this exchange. While this may seem informal, I believe that exposing Benner to my place of work provides context for many of the questions that I would seek to ask her. Having recently attended a local nursing workshop that she facilitated, this setting would currently be convenient and accessible to both of us. As Patricia Benner has become acquainted with many of the nursing leadership team members who attended her workshop, I'm certain that she would feel welcome at our institution. The novice to expert model suggests that formal nursing theories are only of use to novice nurses until they acquire enough experience to override them with intuition. This concept helps me design training initiatives by prioritizing direct preceptorship over traditional learning. I appreciate the value of mentorship from expert nurses to help novice nurses integrate new knowledge. I have found that a sole emphasis on theory-based learning does not necessarily help to apply knowledge or to adapt to challenging new clinical situations. In this sense, Benner's work helps define my role as an educator. I believe that I can best support my team by prioritizing, identifying, and facilitating challenging clinical learning opportunities. For example, during orientation, I provide nurses with essential skills checklists to guide and keep a record of their clinical learning. If I know that a new graduate nurse has not yet had experience with tracheostomy care, then I will pair them with an expert preceptor who is assigned to a patient with a tracheostomy. Research on the orientation of newly graduate nurses reinforces that this approach helps transform theory into practice and facilitates the development of clinical intuition. This considered, I would ask Patricia Benner for advice on how I can best support preceptors that can model clinical intuition for novice nurses. Despite the strengths of the model, Benner's theory is inherently focused on subjective individual perceptions of intuition and mastery. This limits self-reflective linking between theory and practice. In this sense, the novice to expert model discourages open discussion and widens the gap between the theoretical knowing that, taught in educational settings, and practical knowing how required in the field. I often support staff nurses by facilitating clinical reflection. Benner's theory cannot provide guidance for this aspect of my role. Particularly for new graduate nurses, knowledge can be derived from a structured approach to thinking about one's practice. In this regard, I would consult Patricia Benner for her opinion on how academics and practitioners can work together to address the role of reflective clinical culture in the development of said intuition. The concepts of intuition and expertise emerge frequently in the novice to expert model, but are not always clearly defined. Given the challenges involved in measuring level of expertise or intuition, I would also ask Benner how to determine whether we hold the level of intuition necessary to be experts. As Benner's model does not operationalize intuition through an objective metric, this offers the possibility for nurses to over-evaluate their competence and potentially bring about negative patient outcomes. I would proceed to ask whether intuitive expertise is premised on a feeling of clinical agency and independence, or on the basis of some external standard. While competence can be measured through certain clinical indicators, a strong case can be made that intuition is something that only an individual nurse can be aware that they are using. So from this baseline of understanding intuition, I would critically inquire as to what would happen if a given nurse were wrong about their level of competence. I have had multiple experiences correcting novice nurses who hold erroneous perceptions of their ability to perform clinical skills. With Benner's theory making it clear that positive patient outcomes are associated with increasing mastery and intuition, I strongly believe that nurses who practice self-reflection would recognize where they fall on the spectrum. Given the high stakes of frontline healthcare, I also believe that other teammates would be able to recognize and intervene so that this over-evaluation of competence no longer emerges. Thus, even though this may be a fundamental weakness, it is nevertheless overcome by the broader strengths of the model and its structured applicability in understanding clinical expertise. Furthermore, a sole focus on years of experience is not a reliable indicator to make an assumption about the trajectory of a novice nurse into that of an expert. As such, contextual factors such as practice environment can intersect with experience as they pertain to subjective perceptions of clinical expertise. For example, an expert dialysis nurse may feel more like a novice if changing specialty environments to work in psychiatry, as much of this required knowledge is not transferable. The acuity of a practice environment can also impact subjective sense of mastery. Exposure to the ample learning opportunities available in a high acuity practice environment can certainly accelerate the trajectory from novice to expert. Reversely, a highly experienced medical surgical nurse based in a low acuity ward may feel like a novice in a medical surgical intensive care unit. Reflecting on my own practice, the majority of my experience has involved direct client care in an inpatient medicine setting. My focus has shifted towards the community setting while focusing on nursing competency development. Benner's model helps me recognize that while I may have mastered many aspects of acute care nursing, I am not an expert in rehabilitation-based training and teaching yet. I often feel challenged working in a leadership role amongst many seasoned experts. To this regard, I interpret Benner's proficiency levels as fluid and not necessarily a linear trajectory. My transition initially reflected a regression from expert to novice as my role and specialty changed. But as I gain experience, I quickly grasp rehabilitation concepts and am generally considered to be competent by my colleagues. This does not correspond with Benner's suggested stages. Regardless, the novice to expert model helps me seek out opportunities to teach and to gain experience. It also helps me draw on my previous experiences and view new challenges as propelling my professional growth. It also encourages me to seek mentorship from the vast pool of experts that are in my network. So this considered, I would ask Benner how she would apply her model to my personal novice to expert trajectory. Ultimately, I believe that my previous experiences in different nursing contexts and in higher acuity settings contributes to my potential as an educator in this setting. So through her novice to expert model, Patricia Benner provides guiding philosophical and theoretical principles for understanding how nurses progress through their careers and improve on their performances. Despite its gaps, this model contributes immensely to professionalizing nursing by building a structure through which a nurse can measure their own mastery of their profession on the basis of all involved stakeholders and their subjective perceptions. I believe current research on the topic can build upon Benner's foundational contributions so as to further explore the trajectory of the current-day novice nurse into a confident, accountable, reflective, and experienced professional. Thank you.